Hello, and welcome to Llsa 2014. My article to cover is, Does this patient have a severe upper GI bleed? Now, the point of this article is that it's a review article, and it looked at a number of different studies with two goals in mind. And of the thousands of studies that it had that met its criteria, there were very few that actually gave useful information. So those goals were to determine if there is some feature in the history, physical exam, or labs that can reliably differentiate upper GI bleed from lower GI bleed. And once you've established that the patient has an upper GI bleed, are you able to predict which of those patients will require some kind of intervention, whether it be hospitalization for observation, or endoscopy, or surgery, or blood products, or what have you, from those who can be safely discharged for an outpatient endoscopy. Now, probably the most important thing to remember is this is not about hematemesis. If there's hematemesis, it's an upper GI bleed unless there's brains in the hematemesis, in which case your patient is a zombie and you need to take a very different approach. We start by looking at the stool. Melena is produced by passage of blood through the GI tract, and as little as 50 mLs of blood in the stomach can cause melanotic stool, although iron and any bismuth containing medications like Pepto-Bismol can also do that. But bright red blood in the stool, or clots, are almost always from a lower GI source, unless the bleeding is really, really brisk. So a liter of blood in the stomach passed over a 4-hour period will result in bright red blood in the stool, but that's a lot of bleeding. So for the most part, melena versus bright red blood or solid clots help to differentiate. We look a lot at the NG aspirate, the nasogastric tube aspirate. There's no good research one way or the other to say that we should be doing this. And there's actually not a lot of good research to say that esophageal varices are actually a contraindication. But if you are going to do it right. So insert all the way to the stomach, confirm the placement in the stomach, put a minimum of 100 to 200 ml of room temperature water and normal saline in, and then aspirate it and look at it. And we'll talk a little bit more about why all I'm saying is to look at it. So let's start with a history. Just showing up. If you have a patient who says, I think I've got bleeding from my bottom, odds are in favor of it having an upper GI source. 63% of GI bleeds are from an upper GI source, and 37% are from a lower GI source. Although, one of the things that the article's authors noted is there was incredible difficulty in ascertaining the actual diagnosis of the source of the bleeding. And so there's certainly some bias in any article if you don't actually know where the bleeding's coming from to saying one way or the other. There's not really a gold standard that they could find universally to prove where the bleeding was coming from. But based on the bad gold standards we have, most of the bleeds are upper GI. If they have a prior history of an upper GI bleed, the likelihood ratio is 6.2 that this is a GI bleed. If they have a history of a prior lower GI bleed, the likelihood ratio is less than 0.2, which means it's much less likely to be an upper GI bleed, leaving lower GI bleed. If the age is less than 50, they're much more likely to have an upper GI bleed. The likelihood ratio is 3.5. If they're on warfarin, the likelihood ratio is 2, which I guess makes sense. If you're on warfarin, you're going to bleed more from wherever you're going to bleed from, and so that's not a tremendous difference. What turned out to not be useful was nonsteroidal use, aspirin use, or alcohol use. None of those actually predicted upper versus lower GI bleed. In terms of symptoms that patients complain of, if they complain of black or tarry stool, the likelihood ratio was anywhere between 5 and 6. That's pretty good, so that makes it much more likely that it is an upper GI bleed. And epigastric discomfort, 2.3, not phenomenal because, of course, the lower GI tract moves all over your abdomen, so you can have epigastric discomfort from that as well. In terms of signs, if you do the exam and they've got melanotic stool, the likelihood ratio is 25, which is tremendously huge. So melena, it's going to be an upper GI bleed almost all the time. If they're not vomiting up blood and you do a nasogastric aspirate for blood or coffee grounds, emesis, the likelihood ratio is 9.6. So that's pretty strong too. So a positive NG aspirate is pretty useful. Clots in the stool, you shouldn't get clots if you're transitioning all the way from the upper GI tract. So clots in the stool actually are tremendously predictive for a lower GI source of bleeding. So that's useful to know too. If it's melena, dark and tarry, upper. If there's clots, lower. In terms of your laboratory findings, BUN to creatinine ratio of greater than 30 to 1, pretty predictive of it being an upper GI source. You're absorbing all of that nitrogen back in as you're digesting the blood. If the ratio was less than 30 to 1, the likelihood ratio wasn't great, 0.53. So that doesn't really exclude it, it just makes it less likely. Crit less than 20, likelihood ratio was just a little above 2. Not super strong, but more likely than not. And if it was greater than 40, pretty low likelihood. And that's basically because upper GI bleeds tend to bleed more than lower GI sources. But it's not universal, and those were not great likelihood ratios. So if we're going to distinguish upper GI bleed from lower GI bleed, if I, say, had to answer a question on some testing type situation, I might want to put these things in order. So if I had to compare between various findings and tests, melena on exam, that's top there. Likelihood ratio of 25, it's an upper GI bleed. Positive nasogastric aspirate, likelihood ratio of almost 10. Now, if the nasogastric aspirate is negative, it doesn't rule out disease. And in fact, gastric halt really isn't useful at all for anything, frankly. We'll talk a little bit more about that later. BUN to creatinine ratio of greater than 30 to 1, pretty strong likelihood ratio, 7.5, it's an upper GI bleed. Prior upper GI bleed, 6.2, that's pretty strong too. If they're complaining of black and tarry stools, well, that's the patient's perception of melena, pretty high likelihood ratio. Lower age, lower crit, and warfarin. So if I had to compare these to each other, I would answer, say, on an exam situation, the one with the highest likelihood ratio as being your best predictor. Now, you've established it's an upper GI bleed. Now you need to determine if it's severe versus not so severe. You go to the history. If there's cirrhosis or malignancy, the likelihood ratio goes up to 3.7, that it's severe. If they syncopized, 3. That's not tremendous, but it suggests more bleeding, possibly. And analgesic use, and interestingly, it's not a great likelihood ratio, and it was not really NSAIDs. For NSAID history, the likelihood ratio was only 1.8 that it was a severe upper GI bleed versus not so severe. So it's any analgesic use, which is just kind of odd to me and doesn't necessarily make sense. It may reflect the fact that there just aren't a lot of good studies out there. In terms of symptoms, nasogastric aspirate, red blood, likelihood ratio of 3, that it's severe versus not so severe. Red or coffee grounds, 2. No red blood, likelihood ratio is only 0.32. So lack of bright red blood certainly doesn't rule out a severe upper GI bleed, because that's a really not a very strong negative predictive value there with that likelihood ratio. Occult blood, so that's your gastric halt, or its absence is completely useless in predicting severe or not so severe. Tachycardia has a likelihood ratio of 4.9. Well, that makes sense. They're in hemorrhagic shock. Shock generically, and they didn't really define that, likelihood ratio of 2.8. Hypotension, depending on the study, ran from 1.2 to 4.8. 4.8 is pretty good. 1.2 sucks. So it's kind of hard to say what that means. And lack of tachycardia, again, that's not a very good negative predictive value there. That's a lousy likelihood ratio, so not so useful. Labs, if your hemoglobin's low, it's more likely. Well, that makes sense. If your hemoglobin is not so low, it's not so useful. BUN of greater than 90, pretty useful. Means you're bleeding enough that you're reabsorbing a lot of that nitrogen. BUN less than 90, that's a pretty lousy likelihood ratio, so not a very good negative predictive value. White cell count greater than 12 at a likelihood ratio of 3.4. It's a little odd. I guess it's not infectious. It's just your body's demarginalizing everything in your severe bleed, and so that's why you see it. But if the white count's less than 12, that's completely useless in terms of differentiating between the two. And at the end of the day, what the authors really liked was the Blatchford score. If the score was 2 or less, it was unlikely you had severe upper GI bleed. If it was greater than 2, based on this scoring, then it was severe upper GI bleed. And so if I had a test question related to this, I would say that your best predictor is the Blatchford score. And you note they don't even bother with the NG aspirate. And the study authors actually advocated for every patient with an upper GI bleed getting a Blatchford score calculated and recorded. So that's probably something to just keep around in the back of your mind that such a thing exists. All right. If you have any questions, you can either catch me in the hall or email me, or you can let your facilitator today know, and perhaps your facilitator can answer them. Thanks.